All right, next lesson in our medical response part of the recruit program. Remember our plan? Get there promptly and safely. Get in the house, get on the scene, get next to the patient. Do that efficiently and safely. Safe for you, safe for them, safe for everybody. We're all about that. Be nice and be safe. And now there's another step in being good. And let's help that medic crew help the Smiths. Our assessment and treatment. 5-step plan. You've probably learned this by now. Our first step, is it a code? If it's a code, all right, we're working the code. If it's not, which it usually isn't, then we're going to check for circulation, ventilation, oxygenation. And the next step is what this lesson's about. We're going to rapidly find things that are wrong and do what we can to fix them. Following that, we'll do some vital signs and some history. Find and fix with a rapid exam is our focus here. It's a pretty short little lesson, but there's a whole bunch of stuff for us to deal with here. So we're going to find and fix critical wounds and injuries using a rapid exam. It's called a rapid exam because we want you to do it fast. We're talking maybe a minute, 45 seconds to a minute, a full body check. Now, we're going to find everything and we're going to manage important things. We're not going to stop this exam unless we find something critical. Example, hole in the chest. Need to seal that up. We're going to stop the exam, work on sealing that hole, if we don't have any help that we can assign to that. It's a rapid exam. Now, in some cases, think about Mr. Smith having chest pain, sitting in his recliner, watching the ball game, having some chest pain. Does it make any sense at all to rapidly check his full body, to push on his chest and his belly and his pelvis and his femurs and look for bleeding? Because no, it doesn't make any sense. The guy's having chest pain. So maybe in some cases this rapid exam doesn't include every single step, but it's really, and that's fine. That's totally fine for you to omit steps because they don't make any sense. But it's not fine for you to miss steps because you forgot them. So the rapid exam is a quick check of the head, the neck, the chest, the belly, the pelvis, and the femurs. Head, neck, chest, belly, pelvis, femurs. It's a rapid exam, and we're looking to find critical things that we need to manage, and we're looking to find anything else that might be going on. As you go on to EMT, we will do a more focused exam. An example that would be, guy has an ankle injury. He slid into second base, his ankle hurts. There's almost zero chance that he has head, neck, chest, belly, pelvis, femur trauma. And so your rapid exam will find nothing that is important to Mr. Smith, nothing that's wrong, and you'll then go into a focused exam and focused physical, and you'll deal with that ankle injury. But what if it's Mr. Smith who's flown off his motorcycle and smacked into a tree? And so now he could have injuries to the head, neck, chest, belly, pelvis, femurs. So we want to teach this rapid exam in the find and fix part. Teach this rapid exam early on here, okay? A couple of big things that kill Smiths. Open holes in the chest are not good, and they should be sealed up. Initially, we want you to seal that with your gloved hand. The helping hand wears a glove, and it seals up a hole in the chest. Or you get your a partner, somebody else on your crew, to do that while you continue the exam. But when you find a hole in the chest, let's initially seal that up with a gloved hand. Then we'll move on on our second pass when we have time and personnel. Then we will make that a really nice sealed up occlusive dressing, and that air can't go through it. Occlusive meaning air can't pass through it. We'll seal it up with something airtight on 3 sides in case that would be able to relieve some pressure that built up in the chest. And at the EMR level, we don't even deal with this. At the EMT level, we'll talk about a pneumothorax, becoming a tension pneumothorax. It's a big deal. We should worry about it. But at the EMR level, they want us to go fast, and they want it to make this broad but pretty simple. And so that's what we're doing. We're going to seal up that hole with a gloved hand initially. Or what if Mr. Smith has an impaled object somewhere? Well, we don't take out impaled objects. The only time you would consider taking out an impaled object is when you've got to do CPR and it's right where you're going to do CPR, and I'm not even sure it's a good idea then. Or maybe it's blocking the airway. I mean, these are weird, almost made up sort of cases. So in general, almost always, you never remove an impaled object. So that's a couple of the things that we're looking for here real quick. Hey, what about bleeding? Now that's a deal. That's stuff we find. Find it, put pressure on it, directly on it, what's bleeding, and if it doesn't stop bleeding, add a tourniquet, if that's possible. So if Mr. Smith has a gunshot wound to his forearm, and it is bleeding badly, then you need to put pressure on that until it stops bleeding. And if it won't stop bleeding, you keep doing direct pressure and you add a tourniquet closer to his heart, proximal to the wound, closer to his heart. You add a tourniquet and crank the tourniquet down until it stops bleeding. Because tourniquets are not evil, tourniquets are good, tourniquets are our friend, but we shouldn't use them just because we haven't done good direct pressure. We should do good direct pressure, and then if we need to save a life and sacrifice a limb, then we'll put that tourniquet on there. And in some cases, the tourniquet application does sacrifice the limb. In many cases, it saves the life. Now, think about this. Think about Mr. Smith with an impaled knife in his chest. Well, you're not going to remove the knife. You're going to do direct pressure around the bleeding as best you can, but there'd be no place to put a tourniquet. So tourniquets are for extremities, but tourniquets are good when direct pressure has not worked. So we'll practice that, play with that, and that's a key skill that we need you to do. What about general wounds? Well, bleeding is bad, so we stop bleeding because people do better when they have their own blood inside them. So we want to control bleeding as best we can, and we need to cover wounds up so they don't get more infected. And if you can clean some of the dirt and chunks and stuff out of that wound real quick before you put a dressing on, that's fine. A dressing is simply gauze, usually a 4x4, 4-inch by 4-inch piece of gauze, and the dressing covers the wound, and then you secure that dressing with a bandage, whether that's tape or some gauze that comes in a roll called Kerlex that you wrap around there or whatever. There's some new cool dressings out there that have a substance in them that helps control bleeding. So maybe you'll run across some of that. I don't know. But basically with a wound, you want to control bleeding, keep any dirt and things from getting in the wound or staying in the wound if you can, and you move on. And so that's the wound part. We're going to find and fix any wounds, any bleeding, holes in chest, impaled objects, and then injuries. And what we're really talking about here is fractures or sprains, or technically without an x-ray, they say you're not supposed to say the word fracture, but if there's a piece of bone sticking out of the guy's lower leg, I'm pretty sure that's a fracture, and it's okay to say the F word. But we're talking about controlling bleeding by keeping that injury from moving around. So hold the injury still and check them for circulation, motor function, and sensation. CMS. Circulation, motor function, and sensation. Below the injury. Distal means below, away from the heart. Proximal means toward the heart. Not to start throwing in EMT terms, but oh wait, it is an EMT class, just with an EMR component on the front end. So let's start, get you in a good habit, excuse me, of checking distal CMS right off the bat. And then stabilize that injury with a splint. And we'll talk about splints, and we'll play with splints, and you'll find out that there's body splints and board splints and buddy splints. You can buy splints, you can build splints. Splints are cool, but we're going to hold them still, manually splint it, check distal circulation, motor function, and sensation, stabilize it with a splint, and then recheck that distal CMS to make sure we didn't make it any worse. How do you check distal circulation? Circulation below the injury? Well, if there's a pulse you can find down there below the injury, that would be cool. So let's say the man has Mr. Smith has a fracture of his forearm kind of just halfway between the elbow and the hand. If the fracture is there, then distal to there would be the wrist and hand. So maybe you could check that radial pulse to check for circulation. That'd be cool. What if, though, it's an ankle and he has a horribly twisted, probably broken ankle? Are there pulses below that you can check? Well, yeah, there's a dorsalis pedis pulse. We'll show you where to check that. There's a posterior tibialis pulse. We'll show you where to check that. But sometimes those pulses are kind of hard to find. Can you still check circulation if you can't find a pulse? Sure. You could check for skin color. You could check for skin temperature. You could check for something called capillary refill. Capillary refill means you push on the skin and then you let up, and you would expect that that skin would go back to the color it was before you pushed. Capillary refill, you would expect that to happen pretty quick. Matter of fact, you would expect it to happen in less than 2 seconds, which is about the time it takes a lot of us to say capillary refill, kind of like slow. So cap refill is an okay thing to use to check for circulation in an extremity. It's not an okay thing to use to check to see if the man's in shock, but it does tell us about circulation in that extremity. So that would be circulation, either by pulses, by cap refill, by skin color, skin temperature. And the cool thing about bodies is that they are symmetrical. So if his left ankle's hurt, then you ought to look at his right ankle and right foot and compare it to the left foot. So is the not hurt foot a different color than the hurt foot? Is the not hurt foot a different temperature than the hurt foot? What about cap refill in the not hurt foot compared to the hurt foot? So you can compare side to side there, distal circulation. But it's CMS. The M stands for motor function. Can he move it? Can he wiggle it? And the S stands for sensation. Can he feel you touching it? So, example, guy has a fracture, bone sticking out of his lower leg, midway between his knee and his ankle. Distal CMS for that patient would be checking for skin color in his foot, skin temperature in his foot, pulses in his foot if you know where to find them, cap refill in his foot, comparing it to his non-injured foot, and then asking him, can you move, can you wiggle your toes in the hurt foot, and do you feel me touching? Check for sensation. It's not PMS, it's not pulses, it's CMS, it's circulation. So injuries, what do you do with them? Hold them still. Check distal circulation, motor function, sensation. Stabilize it with a splint. We'll teach you how to do that. There's a whole bunch of ways. Then recheck it after you splinted it. And here's the bottom line here. The last thing to say in this lesson, the last thing on this screen, don't miss this. Critical patients get simple splints. The sickest patient gets splinted to a long backboard, a spine board. Femurs get splinted that way, pelvises get splinted that way, lower legs get splinted that way, arms get splinted that way, shoulders get splinted that way, clavicles get splinted that way. Whatever's broken, whatever's injured, whatever's hurt. If the patient's really sick, we tie them to a backboard, call it good, because these injuries are not the deal. Hypoxia and shock are the big deal. So what we're talking about is a rapid exam. Rapid exam, find it and fix it. Seal up holes in the chest, stabilize impaled objects anywhere, deal with bleeding, direct pressure. If that doesn't work, add a tourniquet if you can, if it's an extremity. Deal with wounds. We'd like to keep them clean and control the bleeding. Put a dressing on there, dress it with a dressing, and then secure the dressing with a bandage. And then on injuries, hold them still, check distal CMS, come up with some sort of a splint, recheck distal CMS. If they're way sick, they strap everything to the backboard. The end.